In this module, we will explore concepts related to patient safety. Once completed with this module, you should be able to recognize the significance of patient safety to EMS, discuss the incidence of medical errors, list high-risk EMS activities affecting patient safety, describe how medical errors happen, and describe ways to prevent medical errors. While it should probably go without saying, patient safety is of critical importance to healthcare providers, paramedics included. We, as paramedics, are there to help people, positively impact the care our patients receive, and hopefully improve their healthcare outcomes. The first components in the EMS Practitioner Code of Ethics, as published by the NAEMT, are to conserve life, alleviate suffering, promote health, encourage the quality and equal availability of emergency medical care, and, most pertinent to this discussion, do no harm. Despite this focus on patient safety, however, healthcare providers are only human, and it is inevitable that human errors in care will occur. As a result, the occurrence of medical errors has been recognized as one of the most urgent healthcare challenges in modern times. In 1999, the Institute of Medicine released the document To Err is Human, Building a Safer Health System. At that time, medical error was blamed for approximately 44,000 to 98,000 deaths per year, with a cost to society of anywhere from $17 billion to $29 billion annually. In 2018 dollars, that number would be over $43 billion. Unfortunately, since that time, things seem to have only worsened. A study published by the British Medical Journal in 2016 surmised that deaths due to preventable medical errors in United States hospitals exceeded 250,000 each year, making medical error the third leading cause of death in the United States behind heart disease and cancer. In early 2018, CNBC reported that some studies have reported death rates due to medical error to be as high as 440,000 per year within the United States. So what exactly is a medical error? The Institute of Medicine defined medical error simply as the failure of a planned action to be completed as intended or the use of a wrong plan to achieve the aim. Additional definitions recognize an unintended act, either of omission or commission, that does not achieve its intended outcomes, as well as a deviation from the process of care that may or may not cause harm to the patient. Notice that harm to the patient need not occur for a deviation from appropriate care to be considered a medical error. Whether harm occurs or not is still largely irrelevant to the underlying need to eliminate medical errors from occurring in the first place. Even if an error does not result in harm, medical errors must be reported and addressed to minimize the likelihood of them occurring again in the future. Just because harm did not occur this time does not mean the same error occurring at a later time with a different patient would not result in harm to that different patient. EMS providers and agencies owe it to their patients to constantly seek to improve the care they provide. This means reporting and investigating not only medical errors that occurred, but also near errors that almost or could have occurred if not for some lucky circumstance. In order to minimize the potential for medical errors within EMS, it is helpful to recognize those high-risk EMS activities in which errors are more likely to occur. Anytime the patient is handed off to another provider or party is a point at which error may be introduced. Aside from the risks associated with physically moving the patient from an ambulance cot to a hospital gurney, a failure to provide adequate or pertinent information to the receiving healthcare provider, or a failure of the receiving healthcare provider to listen to the person conveying information can give rise to subsequent medical errors due to a lack of appropriate or adequate information. This ties into another common high-risk yet commonplace activity for EMS, communicating. Whether the communication is over a radio in the back of the ambulance with medical control, via a cell phone in the patient's house with medical control, face-to-face communication between a BLS provider and an ALS provider during a paramedic intercept, through handwritten documentation on a patient transfer sheet, or any other communication through various means between healthcare providers, a failure to adequately and properly communicate on the part of either the sender or receiver of the message can give rise to medical errors due to bad, misunderstood, inadequate, or missing information related to the patient's condition and care. The administration of medication gives rise to significant risk and is another common EMS activity that may be prone to errors. Giving the wrong medication, administering an incorrect dosage, using the wrong route of delivery, failing to identify a patient allergy to the medication, or administering the medication at an inappropriate rate are all common examples of medication errors that can result in significant issues for the patient depending upon the circumstances involved. A failure to maintain an adequate patent airway can be a critical failure within the EMS environment. Endotracheal tube placements into the esophagus without immediate correction is a commonly cited airway error at the ALS level that will have a significant negative impact on the affected patient. Part of what makes the patient handoff process high risk is the potential for EMS to drop the patient. Unfortunately, opportunities to drop a patient are prevalent in EMS in not only the handoff process, but at any time the patient is being moved by EMS. Heavy patients, lack of EMS provider physical fitness, uneven, unstable, or slippery walking surfaces, lack of appropriate staffing to assist in moving a patient, and a high center of gravity on an extended cot can all give rise to the potential to drop a patient. Such an occurrence is considered a medical error and can obviously result in significant trauma to a patient. Also related to trauma are ambulance crashes. In 2014, NHTSA released a presentation on ground ambulance crashes. According to the data, there were approximately 4,500 ambulance crashes per year in the United States over a 20-year span from 1992 through 2011. Just over one-third of those crashes, approximately 1,500 annually, resulted in more than 2,600 injured people per year. 46% of those injured were occupants. Over this same period of time, there were approximately 29 fatal ambulance crashes with 33 fatalities per year. Of these 662 reported deaths, 4% were the ambulance driver, 21% were a passenger in the ambulance, 12% were not vehicle occupants, and the remaining 63% were occupants of the other vehicle or vehicles involved in the collision. Approximately 58% to 59% of these fatalities and injuries resulted while the ambulance was in emergency use, which means a significant portion of these crashes occurred while the ambulance was being operated in a non-emergency fashion. Needless to say, this high-risk activity can have a significant impact on not only patient safety, but the safety of the EMS crew as well. Lastly, spinal immobilization is recognized to be another routine EMS activity that introduces increased risk for the patient. Some studies have even demonstrated the negative impact of spinal immobilization for patients, and many Wisconsin EMS agencies are now utilizing selective spinal immobilization protocols to minimize potential harm to patients given prolonged immobilization on a backboard. Given the nature of spinal immobilization, this activity also has a cumulative risk effect as patient drops become a greater concern for the immobilized patient. Despite the growing amount of technology that seems to invade our daily lives, the providing of medical care is still very human-centric. There is no robot or other automated device that can respond to a medical or traumatic emergency, assess the scene and the patient, craft a working diagnosis given the patient's signs and symptoms, and then deliver stabilizing care while transporting the patient to a definitive care facility such as a hospital. EMS is truly a human-based profession that, at least for the time being, cannot be automated. With that in mind, when medical errors do occur, they are very human-centered. This, therefore, requires us to evaluate human performance in general and reasons for human error. While much research has been conducted on this subject, the Rasmussen model of human behavior has been widely accepted in numerous fields and areas to identify and explain human errors. In 1983, Jens Rasmussen, a recognized expert in system safety and human factors from Denmark, defined three types of human-based errors: skills-based, rules-based, and knowledge-based. A skills-based failure is predominantly an error in execution. The provider knows what he or she is doing and can perform tasks at the subconscious level without having to think about them, but suffers from a slip or lapse. A good yet probably common example would be an overtired EMS provider who is very competent, yet makes an error out of fatigue or a momentary lapse of memory. Rules-based failures occur when providers think they know what they are doing, but fail to recognize contraindications or special circumstances that should have directed them down a different path. Unlike a skills-based failure, the rules-based failure occurs when the provider lacked the experience to perform the task at the subconscious level and his or her misclassification of the situation resulted in the application of an inappropriate rule or protocol. The last type of failure recognized by Rasmussen is a knowledge-based failure. Ultimately, the provider lacks the underlying knowledge or experience necessary to accommodate new situations. Without that baseline knowledge or experience, the provider must utilize intelligent problem solving to deal with the presenting circumstances. When an error occurs in this domain, it is because the provider was ill prepared to correlate new circumstances against a limited existing knowledge or experience. Whether this or another particular model of human performance errors is used, it is critical to understand failures that give rise to medical errors in order to identify them when they occur and develop strategies for reducing or eliminating them entirely in the future. Ultimately, EMS providers and agencies have a strong interest in reducing and eliminating medical errors. Aside from potential legal liability and subsequent financial responsibility associated with medical negligence or malpractice, the last thing EMS providers want to do is inadvertently harm a patient. With this in mind, there are two common domains in which EMS agencies can strive to prevent medical errors: addressing environmental systems issues and individual provider issues. A medical error can result given a failure in one or both of these domains. As far as environmental or systems issues are concerned, EMS agencies should ensure their protocols are clear, adequately shared, and readily accessible for providers. Inadequate lighting can have a negative impact on patient care, making it difficult to read medication labels or identify concerning patient presentations, so providers should strive to ensure the environment in which they are working is well lit. Given the nature of providing EMS in the field, the EMS provider's working environment can be loud, chaotic, and distracting. Controlling that environment to minimize potential interruptions to the continuity of care and the paramedic's decision-making and critical thinking process can help minimize potential errors. The back of the ambulance is typically a much better environment in which to assess a patient and provide care than out in a public location where there is much more potential for distractions and interruptions. Another significant systems issue can be confusing or inappropriate organization and packaging of EMS provider medications. Some vials of different medications are often labeled in a similar fashion and look the same. In a dark environment, differentiating between various medications can be even more difficult for a tired or distracted EMS provider. Being proactive to differentiate medications based upon labeling, containers, storage location, and other factors can go a long way to reduce potential medical errors given a medication administration error. Sometimes there are no environmental or systems factors that lead to a medical error. Rather, the individual EMS provider makes a mistake. Some strategies for reducing medical errors due to EMS provider issues include encouraging EMS providers to constantly reflect upon the care they are providing and their associated actions. Being complacent is unacceptable, and EMS providers must remain astute and alert. Do not simply coast through a call, but be deliberate about everything you do. In addition to this reflection and action, be sure to constantly question your assumptions. You may be an experienced provider, and that experience in the back of the ambulance tells you that the normal saline bags are on the right side of the cabinet, but that also assumes that the person who stocked the ambulance previously put the normal saline bags in the right spot. If the provider functions upon what could be a flawed assumption, he or she may hang and administer the wrong IV fluid before the error is ever noticed. Another related error prevention technique is to recognize personal bias based upon individual values, experiences, and background. Maybe you are a paramedic in a college town called out for an unresponsive 20-year-old male at 2:30 on a Saturday morning shortly after bar closing time. Your experience bias may lead you down the path of just another college kid who had way too much to drink, thus impacting the care you provide. Maybe the patient did not have a drop of alcohol at all and was actually suffering from a diabetic emergency. If your bias impacts your assessment and care, medical errors could very well result. Another way to avoid EMS provider medical errors is for those providers to use decision aids. Unfortunately, human beings are fallible, and relying on memory or doing things like complex math in your head can lead to errors. Maybe you are at the end of a long 24-hour shift and, for whatever reason, cannot remember the dosage of a particular medication. Do not guess. Use a ready reference guide to look it up. There are a lot of medications out in the market, and maybe your patient is taking a medication you have never heard of before. Use your available resources, such as a pocket guide or even a smartphone, to look it up. Also, do not hesitate to use your team members to verify what you observe or think should be done. Before pushing a medication, have a second person on your crew verify the dosage you drew up. Are you unsure about whether or not a procedure should be performed? Contact online medical direction for guidance. Admittedly, this brief presentation barely scratches the proverbial surface of factors related to patient safety in EMS. For the EMS provider taking initial paramedic education, the information in this presentation is adequate to help impart the importance of patient safety and quality in providing EMS. If you are interested in learning more on the topic or are somehow responsible for safety and quality within your EMS agency, it is strongly recommended that you pursue additional learning opportunities and explore other resources on the subject. EMS.gov has a web page dedicated to NHTSA's EMS Safety Initiative. You can even find the 2013 Strategy for a National EMS Culture of Safety document on that page. As far as additional education is concerned, the National Fire Academy's Fire and Emergency Services Higher Education Initiative recognizes formal EMS education as an important component in the development of EMS leaders and executives, and has defined a model curriculum for educational programs that includes courses on risk management, safety, and quality. Waukesha County Technical College actually has a technical diploma program in EMS leadership and management that includes these courses. The program is offered 100% online, and each of the 6 8-week-long courses is offered in an accelerated format. Students may join the program at any time at the start of one of the courses. It is also not required for a student to complete all the courses unless the student's goal is to obtain a technical diploma in EMS leadership and management. This means students have the option of taking single courses here and there to acquire the requisite knowledge associated with the individual courses in which they are interested. Given your completion of this brief module, you should now be able to recognize the significance of patient safety to EMS, discuss the incidence of medical errors, list high-risk EMS activities affecting patient safety, describe how medical errors happen, and describe ways to prevent medical errors. If you would like more information on the subjects of patient safety and quality in providing EMS, you are strongly encouraged to evaluate other resources or take additional coursework related to those subjects. This presentation was prepared by Waukesha County Technical College in Pewaukee, Wisconsin, and is distributed with an attribution, non-commercial, share-alike 4.0 International Creative Commons license. Copyright 2018 Waukesha County Technical College. For information on WCTC's numerous fire and EMS educational offerings, please visit us online at wctc.edu.